So Axemin injection is indicated for PET imaging in men with suspected prostate cancer recurrence based on elevated prostate-specific antigen levels following prior treatment. That could be anything from hormonal therapy, radiation, or prostatectomy. The indication is quite broad. This is our safety information. Image interpretation errors can occur with Axemin PET imaging. A negative image does not rule out recurrent prostate cancer, and a positive image does not confirm its presence. The performance is affected by PSA levels, and I'll show you a nice chart on that shortly. Severe allergic reactions, including anaphylaxis, may occur, although we have not had any cases to date. The use of Axemin does contribute to the patient's overall long-term cumulative radiation exposure, but it is quite minimal, and adverse reactions were reported in about less than 1% of subjects during clinical studies with Axemin. So to report adverse reactions, you can call this number, and full prescribing information is available at axemin.com. So this is the important safety information that appears in our prescribing info. It's well tolerated. Hypersensitivity is seen in all package inserts, including FDG, and we've had over 12,000 patients to date, and no hypersensitivity or anaphylaxis at all. So want to go very briefly over prostate cancer and biochemical recurrence. Up to a third of men treated for primary prostate cancer will experience BCR in about the 10 to 15 years following treatment, and about a third of these men will develop metastatic disease within 8 years. So evidence of the disease is generally based on PSA level alone. So really knowing the location of the recurrence is critical, as this guides the optimal choice of therapy. So detecting localizing recurrent prostate cancer is really critical for optimal disease management. There's a need for new imaging techniques to optimize management in patients with rising PSA levels, and I know we've mentioned PSMA previously quite a bit. We think that positive imaging findings occur in about 10 to 11% of patients overall with BCR. So it's very important to identify where in the body the recurrence is, and it can be in one or more sites or at the same time. When the doctor knows where the recurrence is, they can really best determine treatment. So the current imaging tests can, at the moment, identify a small number of recurrences. What is a PET-CT scan? It combines the two imaging techniques. A PET scan shows the physiologic functional changes in the body, and CT shows the anatomical changes. When you fuse these images together, you have both the functional and the anatomic information about the function and location of the tumors. So you can see here this shows a presacral lymph node. So with the fused image, you can go back and forth, line it up. If it's suspicious, you can go to the PET-CT, which combines the two technologies. These were mentioned previously today. So FDG is indicated for PET imaging in oncology, cardiology, and neurology. Sodium fluoride indicated for PET imaging of bone to define areas of altered osteogenic activity. So again, FDG is a glucose analog and most widely used, but it's not for prostate cancer due to its indolent growth and high urinary excretion of FDG. Sodium fluoride does not detect soft tissue lesions. C11 choline, also mentioned previously, a radioactive diagnostic agent for PET imaging of patients with suspected prostate cancer recurrence and non-informative bone scans, CT or MRI. And in these patients, the C11 choline could help identify potential sites of prostate cancer recurrence for subsequent histologic confirmation. There are issues with C11 choline. It does have a 20-minute half-life, and you need a cyclotron on site, so it's not very patient-friendly. Mayo Clinic does not use it at PSA levels less than 2 due to its low perceived sensitivity. And there is one published head-to-head study with Axemin and C11 choline, and Axemin outperforms C11 in every statistical category. Onto PSMA, it's an investigational agent not approved currently by the FDA. It's a protein that's found on the surface of the majority of prostate cancer cells, but again, it's not prostate specific. There's over 20 ligands to date. Some are F18 labeled, gallium labeled, but none are commercially available. Axemin was approved by the FDA on May 27, 2016. The information that was supplied for FDA approval supports the use of Axemin as a diagnostic PET agent to aid in the detection of recurrent sites of recurrence in patients with BCR. This is the mechanism of action. It's a synthetic amino acid which is actively transported into cells by these two transporters, ASCT2 and LAT1. It's not metabolized or incorporated into newly synthesized proteins. PET imaging studies have shown that it's preferentially taken up into prostate cancer compared with surrounding normal tissue, and quite important, the visualization of the image is not obscured by bladder uptake. So it's upregulated into prostate cancer cells, taken to the cytosol. It's not specific for prostate cancer. This mechanism of action can happen in other malignancies as well. Just briefly to go over some biodistribution and dosimetry. You can see the pancreas and the liver here light up quite intensely. So axamin uptake is highest in organs with high levels of amino acid uptake: liver, pancreas, bone marrow. Very little brain uptake, and with increased time you will see increased skeletal uptake as well. The red box you can see here is the first bed position where there's very little bladder activity. Excretion mainly urinary, 3% excreted in the urine, 10% through the GI tract, and the rest washes out over time. 10 to 15% of patients are early excretors, so you need to be aware of that on the images if you see a little bit of bladder uptake, and we do ask all the patients void before use. This is a time activity curve. It shows that the optimal PET imaging with axamin is achieved at an early time point post-injection. You could see the prostate line here in red. Yeah, there's rapid uptake of the tracer in the malignant tissue. The bladder line here, appropriately colored yellow, slowly increases and then it levels off. Lymph node line in green, similar to prostate. So the purple box right here is really the critical time as you start imaging around 3 to 5 minutes and finish around 30 minutes because the target to background ratio is best within that 30-minute time span. Dosage and administration. Our recommended dose based on our clinical studies is 10 millicuries plus or minus 10%, is administered as an IV bolus followed by a flush. We do ask the patients avoid any significant exercise for at least 1 day prior, and that they should fast 4 hours prior to administration. You inject them on the PET scanner table. Position the patient supine, arms above the head. CT is done for attenuation and anatomic correlation, and the PET scanning is done 3 to 5 minutes after completing the injection. The acquisition is caudal to cranial, so mid-thigh to the base of the skull, and the heads of the femur need to be in the first bed position to really get a good image of the pelvic area. And scan time is about 20 to 30 minutes. So our clinical experience has shown adequate image quality combined with a reasonable radiation exposure at a dose of about 10 millicuries. So clinical study information and the data, very brief data that led to our FDA approval here. So total of 596 patients with biochemical recurrence underwent 651 flucyclovine scans. The detection rate on the whole body level was about 68% and less as you get into the prostate bed and so forth. More distal nodal involvement was detected in about 26% of patients overall. Positive uptake in bone, I guess get asked about this quite a bit. Does it show bone? Positive uptake in bone in this study was shown to be in about 9% of patients. But, and this is a big but, a significant number of these patients were selected to be negative on bone scans. So the patient population in this study had been skewed in that manner. In the past few weeks, I've seen an uptake in the femur, thoracic area, so it is capable of picking up bone if you have come across that before. So the results are affected by PSA levels, with, in general, lower PSA levels in patients with negative scans than in those with positive scans. At the lowest PSA quartile of less than 0.79, the detection rate was about 41% on the whole body level, and then you go up to about 60, 75, and 85% as you get into higher quartiles. So higher PSAs, higher detection rate with the axamin scan. This is our safety information. Overall, the safety profile is quite good. Any event is just a summation of everything below it. So we had solitary cases of constipation, headache, some reports of injection site pain and erythema, but overall the safety profile of axamin is very good. The Falcon trial was an investigational trial in the UK. Final analysis is underway and the study is complete. The primary objective was to assess the clinical impact of flucyclovine PET CT scan on patient management. The primary endpoint examined the percentage of men who have their management plan changed after a flucyclovine PET CT scan. It's not in the label at the moment, but it's been presented at congresses in the past, including at ASCO GU. The results for change in therapeutic management showed that a majority of those imaged, about 61%, right there, had a change in management post-scan. 41 out of 52 had a positive flucycline scan and 11 were negative. 60% had a major change. The recruitment was subsequently stopped as the pre-specified condition for overwhelming efficacy was met. A similar trial called LOCATE was done in the U.S. Jerry Andriol is presenting the results at AUA, and the results are fairly consistent with the Falcon trial in the UK, but unfortunately I can't comment much more at the moment on that. So just to summarize, there's really a clinical need for new tools for detecting biochemical recurrence prostate cancer. The diagnostic accuracy of standard imaging tests for identifying sites of recurrence is low. Axemin contains flucycline, an F18 labeled synthetic amino acid analog with a 110-minute half-life, so it's very patient-friendly. It's shown in our clinical studies to be effective at detecting recurrent prostate cancer, minimal adverse reactions, typical scan time is about 20 to 30 minutes, and 110-minute half-life really expands provider access through our partner Siemens PetNet, who does the manufacturing and distribution. So just very briefly want to go over a few cases. These patients have a mix of radiotherapy and prostatectomy, so we'll get an idea of PSA level. I get asked all the time, what PSA level should we use the Axemin scan at? There are SUV values in these studies as well here, but for interpretation training, they will be trained to do a visual read as opposed to looking at background regions. But for demonstration purposes, SUV levels are included here to see the intensity of the uptake regions. The first case is a 57-year-old patient, had radical prostatectomy and bilateral staging pelvic lymphadenectomy, rising PSA to 0.41. If you could play the image, please. So looking at the MIP, to get started right here, there's a difference in the distribution compared with FDG. You can see the pancreas and the liver are the most intense organs. There's very little renal and absent bladder activity. There's a focal lesion right there in the pelvis. Mild splenic, marrow, bowel, and muscle activity is minimal at this time point. Significant blood pool activity could indicate early acquisition or altered biodistribution. If there is excessive muscle uptake, then it could be delayed uptake or altered biodistribution as well. You can see the SUV of the target lymph node down there is way above background of marrow at L3. So again, the interpretation of the image is a qualitative read, not quantitative, but for areas of borderline uptake, you can compare SUV values, and we're looking again for asymmetry in the image. Second case is a patient who had a post-radical prostatectomy, negative lymphadenectomy, PSA going up to 0.73 and negative on other imaging modalities, and the Axemin scan showed a left presacral node. So you can see there's diffuse Axemin uptake here in the bone marrow, which really equals normal biodistribution. For small lesions less than a centimeter, we think focal uptake greater than blood pool is suspicious for prostate cancer. Large lesions, uptake greater than or equal to bone marrow is suspicious for prostate cancer. Very briefly on reimbursement, and I can give you contact information for the sales and commercial team if you need more information on this. It's covered by Medicare. As of about 2 months ago, flucycline was put on the NCCN guidelines, and because of that, it's really opening up the doors for coverage by commercial insurance. That's going to take a little bit of time until they get on their algorithms, but slowly and surely, commercial insurers are starting to cover it. If you need additional information or assistance with reimbursement, we do have a dedicated reimbursement hotline as well. Thank you again for having me here. I'd love to hear about any of your first scan experiences or patient experiences with Axemin as well.
Thank you. There's no question that these novel imaging agents are changing our perspective on the disease. And, I come out of an institution where we're getting tons of PSMA PETs and haven't actually done the Axemin. I have just a quick technical question for both you and Larry. Whole body MRI versus CT with these PET, does it really matter?
So I was going to mention a little bit, but there's a new generation of PET MR machines. I guess that's what you're referring to. So there are potential advantages there, right? Because the MR most likely gives more information, certainly gives about the same anatomic information as the CT, and there's probably more functional information. That notwithstanding, they really aren't that many of those machines in the country, except for some premier institutions. So and it's expected certainly for a while still to be kind of a research tool.
Yeah, okay.
But again, that's something that in a few selected sites.
So theoretically, could Axeman be given with full body MRI if it was determined down the road? That,
yeah. Oh, yeah. Sure.
So this is just a tracer. And,
Yeah.
Our experiences in clinical data has been with PET CT, but we have a robust investigator-sponsored studies program, and we are looking into use with PET MRI as well.
I guess I sort of struggle with where to use this. I think if someone's PSA is changing slowly, you don't need this. They're not gonna die of prostate cancer for many years maybe. If it's changing rapidly, they're gonna do poorly. You're probably gonna start them on hormonal therapy. What would be useful is a double-blind study in the salvage setting to know that if you have a positive scan, they don't benefit from salvage. I mean, I think that's really where the critical need is. Not whether you change management, but does this will a positive scan tell you that salvage is unnecessary and that you're just harming patients? And I think if that data were available, then I think there would be significant value to the test.
Absolutely. The company is 2 years old. We have a lot of data gaps. We don't have a lot of data developed. We are trying to get information such as that through ISS studies. I'd be happy to speak with you after about it if something that you'd like to do. In terms of when to use it, it's really at your discretion. You know what the FDA approved label is. And the other important part is PSA kinetics. So we think the high Gleason scores, shorter PSA doubling times are very important in using the scan as well.
Do you have any experience in assessing response?
That's something we're just looking into for ISS studies as well, but we don't have specific data on that. But that's a big area that we're looking into soon.
So,
responsive therapy.
Shashrani at Emory has an R1 looking at the randomization question and trying to slide that into cooperative group study before the window of opportunity is fully closed. And, we talked a little bit earlier about how the Europeans and Australians might sort of rescue us. But in this case, it might be the Canadians that help us out as well. So the randomization is becoming increasingly difficult in the U.S. environment, but the rest of the world is waiting to be convinced.
Yeah.
And we are too, by the way.
Yeah.
We just can't do the study.
Yeah.
Question. You mentioned the background uptake in the bone marrow being homogeneous and symmetric. We've seen several cases of focal bone marrow uptake with no abnormalities on MR. Do you have any experience of what that means? And do you guys any follow-up with tissue biopsies or anything?
Generally, we don't. Did you say it was with MRI?
No, the focal uptake on the examine PET, but then the MRI shows no abnormalities.
I can't really. There's not much information on that. So if that's specific experience, we have some imaging services, imaging service that we use that could try to answer that question, but it's not something that I've had an experience with or heard of.
Great. Hey, do you know